From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University on Medscape Cardiology and the Heart.org. During the course of the COVID pandemic, we've certainly every week continued to learn a lot about the disease, about its multiple manifestations. We've talked on this program just recently about some of the health inequities that we've seen emerge during the COVID-19 pandemic. What we want to do today is turn our attention to an issue that arose from the early observational reports of the disease and has continued to be a hot topic of conversation amongst clinicians taking care of COVID-19 patients. And that's the associated problem of thrombosis. And we've seen reports with varying degrees of incidence of thrombotic disorders, both on the venous and the arterial side. We've seen reports coming out recommending thromboprophylaxis. We've seen reports where people are starting to explore full dose anticoagulation. And we've also seen people worried about the risk of full dose anticoagulation in this group of patients. I thought that there was no one better to actually inform us on this topic than my good friend and colleague, Dr. Mary Cushman. Mary is a professor of medicine and pathology at the University of Vermont, where she is also the medical director of the Thrombosis and Hemostasis program at the University of Vermont Medical Center. Mary, thank you for joining us on Medscape Cardiology today.
You're welcome. It's great to be with you.
Mary, you are the perfect person to have this conversation, given both your research interests, your research expertise, and your clinical insights. And so let's start at the beginning. What has been observed in the area of venous and arterial thrombosis in patients with COVID-19 infection?
Yeah, that's a really great question. I think from the macrovascular perspective, early reports suggested high rates of deep vein thrombosis and pulmonary embolism in patients admitted to hospital with SARS-CoV-2 infection or COVID-19. And this, it's really a little unclear as to what the actual incidence is, as you suggested in your intro. Early reports suggest incidences of deep vein thrombosis and pulmonary embolism up to 30%. I think that's probably not correct. The sicker patients get, the higher their risk, just like any medical inpatient where the risk is increased. Later studies coming out are suggesting lower rates, closer to around 10%. There's a paper in Press and Blood out of 5 hospitals in your hometown, Boston, that suggests this lower incidence of venous thrombosis. And so we're not 100% sure yet, but we do know that there's something different about what this infection is doing to the clotting system compared to other infections, this what we call COVID coagulopathy. And that this coagulopathy seems to be prominent and it seems to predispose to thrombosis. So venous disease is the most important, I would say, macrovascular complication. Now,
what about on the arterial side?
Yeah,
because certainly our audience is mostly a cardiovascular audience, and they're interested in things like, does it trigger acute myocardial infarction? Does it trigger stent thrombosis? What about my AFib patients?
Right. And, I like to think the venous side is a cardiovascular disease too. So
touche.
Listeners are paying attention to venous thrombosis and becoming more educated about it. But I think that on the arterial side, I think the obviousness of an association is a little less. I think we are recognizing that people have elevated troponins and such, and there have been some suggestions that large vessel stroke might be an issue in young people who have this infection. But I think the epidemiology is not as prominent on the arterial side in terms of what exactly to expect. So I think that if anything, what observations have been made is that cath labs are less busy, and the big concern is that the mitigation of infection in the population, the stay-at-home measures and such, have been frightening patients from coming for care. So that that may be a bigger problem than arterial disease complications related to the infection itself.
Yeah, that's been an issue that many of us have been talking about, that we've seen somewhere between a 30 and 50% decline in the acute presentation of suspected strokes and suspected MIs. And I think you're right that it seems that the predominance of the observations are that what COVID seems to be associated with is an increased risk of venous thromboembolic disease. Mary, is the incidence higher than we see with just critically ill patients with other viral infections? Like if you take a very sick person with flu, do we see the same association?
I think it is probably higher. I think, again, it's a little unclear. So, for example, risk adjusted for severity of disease compared to any other ICU patient, for example, it's probably higher, I would say, based on the preponderance of evidence. The thing that people are noticing in the large hospitals that have a heavy burden of this disease is that the standard DVT prophylaxis doesn't seem to be suppressing thrombus like it does for other patients. Now, remember that in critically ill patients without any thromboprophylaxis, the rate of VTE might be as high as 20%, and you can reduce that perhaps by half with thromboprophylaxis. So thromboprophylaxis isn't all that great in terms of its efficacy, but it's obviously better than nothing.
I'm going to come back to that because I want to tease out the details of that. What do we know about the biology? And I'm going to comment on two things I've seen in the literature that have fascinated me. One of which is the biomarker papers, and that's a particular area of interest and expertise for you, with an elevated IL-6, an elevated D-dimer, not so much what I would think of as like the markers of DIC, the changes in PT, PTT, thrombocytopenia, but this inflammation D-dimer intersection is a really interesting one, and you've written a lot about that. What's your take on the literature there, and what's that telling us maybe about the pathobiology of COVID and thrombosis?
Yeah, this is a story that we really need to solve, and the first kind of appearance of this idea came out of papers from China, where this prominence of elevated D-dimer and elevated pro-inflammatory markers like IL-6 and ferritin and CRP was described. And we all thought, oh, OMG, there's a DIC here. This is DIC, but it's not DIC like we normally think about it. So the fibrinogen tends to be high, not low. Fibrinogen is an acute phase reactant, of course. I don't really think of it. It's a clotting factor, but from the biomarker perspective, it's more responsive to acute phase. And so it's not like DIC where you see elevated protimes, lowering fibrinogen, elevating D-dimers. You see high D-dimers, high pro-inflammatory biomarkers. You see mostly a normal protime. And once patients progress to more advanced disease, they then start breaking down and start developing more consumption of clotting factors, whereby their protime will elevate, their platelet count might drop. And it's really, once patients develop the more classical DIC picture, that's a really bad harbinger that they're dying, essentially.
So it doesn't start as a consumptive coagulopathy. Over time, it makes the transition to a consumption state, and that is as you've said, that's a bad marker.
Yeah, and so I think what has become pretty standard is when patients get admitted to the ward with this infection, these biomarkers are checked. So from the hematology community, we're recommending, checking the D-dimer, fibrinogen, CRP, along with the admission labs to see where patients stand. And I think that can give you clues as to who's going to progress. We know people who have higher D-dimer at the beginning have a more adverse course, higher risk of death. So D-dimer is not a fibrinolysis marker. When you study the epidemiology of D-dimer in healthy people, it's not marking hyperfibrinolysis usually, it's marking increased fibrin formation. So it's correlated with fibrinogen, it's correlated with procoagulant factors like factor VIII, which is also high on admission in these patients and can be very high. And it's correlated with pro-inflammatory biomarkers as well in healthy people. And so D-dimer is a marker of fibrin formation. And I think that if you just think about that for a moment and then consider some of the pathology findings that have come out, I think what we're starting to understand is that there's an intense stimulus with this infection to lay down fibrin. And that probably comes from endothelial damage. I haven't seen much on biomarkers of endothelial function or adhesion, apart from factor VIII and von Willebrand factor, which we think of as biomarkers of endothelial function, because factor VIII is stored under the endothelium. And so when there's endothelial damage, levels go up very high. Remember, factor VIII is the clotting factor that's preserved in patients with advanced cirrhosis because it's stored at subendothelium. So even though it's made by the liver, the levels can be fine even when you have cirrhosis.
So that was the second paper that I wanted you to talk about. The one that was in the New England Journal about the lung autopsy, and really looking in a series of, I think it was 7 or 8 patients at the lung findings, and they did see this angiopathy, and they did see disruption of the endothelium. What did you think of that, and how do you start to put that into the story?
Most patients who've died with this have not had autopsies, but so, thinking about why did those particular patients have autopsies and other patients didn't is, we don't know the extent of how much this means, but I think that it's really telling. And, we're starting to believe that the coagulopathy marks people at risk for progressive lung disease, perhaps because it marks this possibility that the person's going to develop or is already developing microthrombi in the lung. And in fact, there's this idea that people with this disease who present like they're having PE, it's not because they're having DVT associated with their PE, but they're having in situ thrombus, maybe even in the larger vessels. Now, you wouldn't be able to distinguish the difference between the two potentially on a CT angio, but most of the patients can't get CT angios anyway because they're too ill and they can't go to radiology. So, I think this is really telling, and it raises the issue that we'll talk about later about the potential ways you could shut off the fibrin formation. There's a paper just out actually that suggests that the virus actually could infect endothelial cells. And if the virus is infecting the endothelial cells, then that's not typical in virology, from what I understand. And so if this were to happen, this could explain a lot of these biomarker changes that we're seeing, because that endothelial disruption and the development of these microthrombi, or maybe even macrothrombi, but probably microthrombi in the lungs, which is where the virus is. So I think it's a really cool area to consider further.
Here's a disease that we weren't really thinking about several months ago, and now fast forward, the amount of scientific information that's been pouring out daily is really extraordinary, and we've really learned a lot. Yeah,
when we had the SARS epidemic, it was not as prominent, but we had the feeling, at least in our own ICU here at the University of Vermont Medical Center, we had the feeling that those patients were having more thrombosis as well. Maybe that the SARS-CoV-1, the SARS virus that we were dealing with a number of years back, had similar impact that we just didn't recognize because it wasn't as severe. There wasn't as much of an outbreak. And so we didn't have the urgency to study it. And I remember one of our fellows actually collected a bunch of samples from some of those patients, and we never did anything with them. We kind of kept them in the lab, and I think we should probably go back and try to dig those out. But I think we as hematologists had the sense that we were seeing more thrombosis with those patients as well. And there was just less research at that time on that disease.
Well, you may have seen this is with the AHA, where we granted a series of rapid challenge grants. One of them is to study the thrombotic complications of the disease given to investigators in New York City. So certainly high volume of patients, high likelihood that they have samples on those patients. And it's going to be interesting to see what we learn from that grant about the thrombotic complications. I'll say as a total aside, having visited you and others at the University of Vermont several times over the years, you have an impressive biobanking system up there for thrombosis. And so if anybody would have had the SARS blood remaining, it would be the University of Vermont.
I think it probably is in the freezer somewhere. I just have to find a moment to figure out where.
Let's turn our attention then from observation and biology to clinical practice. You've already told us what you're recommending from a hematology perspective as to the diagnosis piece. Talk to us about thromboprophylaxis. People have said, we've got to use standard, low molecular weight heparin, et cetera, in this group of patients to prevent thrombosis. Reasonable strategy? Is that what you're recommending? What kind of dosing, et cetera?
Yeah, I've been involved with a couple of consensus groups. One from the American Society of Hematology. It's a relatively small group, and one that was published, that was a much larger group, about 45 authors, published in JACC last month. Vic Deli is the first author. And in both groups that I've been involved with, the conclusion, based on expert consensus, because that's all we have right now, is that all patients admitted to hospital with COVID-19 should receive DVT prophylaxis using standard dosing. So, if it's enoxaparin, it would be 40 milligrams once a day, or unfractionated heparin, 5,000 units twice a day. And at the same time, there has been the emergence of these institutional protocols and other opinions, and perhaps patients who have obesity should be given higher doses, or all patients should be given higher doses. And then some people who suggest that those admitted to the ICU even be given full dose anticoagulation empirically. And so those of us who are involved in creating guidance documents really have tried to stick with what we know from the literature to be effective and safe, because anytime you give DVT prophylaxis, there's a risk of bleeding complications. So we've stuck with recommending standard intensity DVT prophylaxis. Also, the International Society on Thrombosis and Hemostasis has also put out a consensus guidance just a couple weeks ago that concluded the same thing. And so people's emotions want to say, do more. And I think a lot of this is driven by what's been observed in the large hospitals. And I respect that. And I think for a given situation that you're in, based on your experience, if your hospital develops a recommendation that might differ from what guidance documents suggest, I think that's okay, because everybody's just trying to do the best they can do. But at this point, we really strongly believe that anything more than that should be documented in a randomized trial before it can be recommended broadly.
The pandemic, in many ways, has shown us once again that clinicians are much more willing to make the sin of commission than the sin of omission. Mm-hmm. And people say, well, I got to do something. And I've never agreed with that, because if you don't know, what you ought to do is study it. You ought not to just say, oh, I think this is the way, because you actually may be doing more harm than good. And the only way you figure that out is by systematically studying it. And the hydroxychloroquine is a great example of that. And people were passionate. No, we have to use this. Now the randomized evidence is suggesting, well, no, you don't. And
there's a paper in Press in Blood. It's up on the accepted articles section, so it hasn't been formatted yet. Out of 5 hospitals in Boston, looking at predictors of outcome, and they showed and replicated that higher D-dimer levels at admission were related to thrombosis outcomes. But guess what? The higher D-dimers at admission were also predictive of bleeding complications during hospital stay. You have to have the trial to really answer the question. And emotions run high, especially because these patients get so sick so fast. And I get that.
I get that as well. I mean, we all take care of really sick people, and you want to do something. I mean, that's the nature of the work that we do. You want to do something, but we also have to step back and say, how are we going to learn about this in a way that we can help not just this patient, but subsequent people to come. Let me ask you 2 more questions, Mary. Are there particular reasons to think outside the D-dimer story about who might be at highest risk of bleeding with the disease? Or is it, the usual case? small body weight people, elderly, people with comorbidities? Is it the usual things that predict bleeding in this group of patients?
I don't think we know enough about that yet. And honestly, in hospitalized patients, bleeding is common. Think about all the people you admit in the hospital for one reason, and then they have a GI bleed. And we don't really understand the risk profile of those in the general medical inpatient population who are at increased risk of bleeding. Apart from if you give people anticoagulants, they have increased risk of bleeding. Again, COVID is magnifying everything. So in the COVID setting, maybe we'll learn more because of the intense interest and resources and creative thinking that are being put into it. We can learn things that will be applicable to other patients as well. But yeah, I don't think we have a good handle on that.
And then my final question for you, are you aware of trials that are ongoing in the area of full dose anticoagulation?
Yeah, in fact, I happen to be co-PI of one of them. So we've launched a trial called the Rapid COVID Coag trial. And this is, my co-PIs are Michelle Scholzberg, who's a hematologist at Toronto, University of Toronto, and Peter Uni, who is also at the University of Toronto. And this has been an amazing experience. And Bob, I'm not a clinical trialist. I'm a chronic disease epidemiologist. And yet now with COVID, you have to do what you have to do to solve these research questions. And so I became engaged with Michelle and Peter in designing this study. And we now are open in 2 hospitals in Toronto, and soon to open about 10 hospitals in the United States. And we have over 40 hospitals in Canada, the US, and other countries who are in various stages of getting activated. And it's a fascinating experience because what we're testing is the impact of full anticoagulation with heparin or low molecular weight heparin in ward patients with COVID-19 who have elevated D-dimer or hypoxia with a D-dimer elevation, but not quite as high of an elevation. And the comparison group is standard DVT prophylaxis. So enoxaparin 40 or unfractionated heparin 5,000, BID or TID. And the primary endpoint, which I think you'll also think is cool, Bob, it's not thrombosis. It's transfer to the ICU or the need for mechanical ventilation or death at 28 days.
So you went for the big hard clinical outcomes.
Yeah, we're trying to see if the treatment will impact the progressive lung disease.
Yeah.
And
that's a great study. How big is it going to be?
It's going to be 462 patients, but it has an adaptive design. So there'll be an interim analysis, and then the sample size can be modified as needed. And with that sample size, we'll have 90% power to detect a meaningful difference between the groups. The first cool thing about the study is the endpoint. The second cool thing is the biorepository that we're going to collect. So that we can do correlative science. We can look at all of the variety of biomarkers we've been talking about, plus different ones. We've developed in our lab an assay for soluble ACE2, which has gotten a lot of attention. And cool thing number 3 is that based upon the sites that we're prioritizing for activation, we are prioritizing sites that have very high racial minority representation. And we really want this trial to have upwards of 50% non-white participants, primarily Black and Hispanic.
Another long-standing interest of yours.
We want to try to understand the racial disparities in this disease. We actually have centers who are willing to start before we have full funding identified. We're starting the study based on, pilot funding or really, honestly, people working for free.
Well, that's been another amazing part of the pandemic is the amount of research that's come out without demonstrable funding. I mean, I think the funders, HA, NIH, et cetera, are catching up, but certainly a lot of work came out before this started. So kudos to you and the Toronto-based investigators. That sounds like a fabulous study. We'll plan on having you back to discuss it because I think it will be, whatever it shows, it'll be an interesting set of learnings.
Yeah, and hopefully the network that we're putting together of centers can address other questions as well as we go on. Yeah.
Always a good way to do it, to get those networks put together. But I want to thank you, Mary, for joining us here on Medscape Cardiology. We've had a great discussion about COVID-19 and the risks of thrombotic disorders, particularly on the venous side, but not exclusively. We've talked about the biology, we've talked about potential treatments, and it's been great to hear about a new clinical trial coming in this arena. I want to thank my guest, Mary Cushman, who is a professor of medicine and pathology at the University of Vermont. Mary, thanks for joining us here on theheart.org.
You're welcome. It was great talking with you.